All right. Welcome and good morning. I'm Dan Cabrera, one of the hospitalists at Harborview. I'm here to introduce our speaker for the day, which is Dr. Naomi Shike. Naomi started her education at Dartmouth College, where she majored actually in Spanish, and then actually got a master's at the London School of Economics and Political Science in the Department of Social Psychology. Then did her medical training at Weill Cornell College in New York. Before coming here for her residency in internal medicine, and then stayed on for chief year at the VA as a clinician teacher fellow as well. Currently, she splits her time between being a hospitalist with me at Harborview and also as an outpatient provider at the Pioneer Square Clinic. She has been involved in a number of efforts here in the department in her short time. She is one of the original members of our Residency Diversity Task Force, which has now become a Residency Diversity Committee. She also is a member of our Department of Medicine Diversity Council and has taken on a number of workshops and efforts centered around diversity, equity, and inclusion, including talks like this, but other talks centered around implicit bias. And she also is our site lead at Harborview for our UW Health Professions Academy, which is a bridge pipeline program to get underrepresented people into medicine. So without further ado, I'd like to welcome Dr. Naomi Shike. Thank you.
Good morning, everyone, and thanks for coming to my talk. Let's get this working. Yeah, okay, we're all set. So my talk today is going to be about, race in medicine, and specifically shedding light on a lot of the myths and fallacies that permeate the way we think about this. I have no disclosures, and for our CME learning objectives, by the end of this talk, participants will be able to define race and importantly understand the difference between race, genetics, and ancestry. Using that information, we'll learn about the pitfalls of the way that we use race as a variable in the medical field. And finally, by the end, hopefully you will all understand how to use the concept of race in a beneficial way to illuminate the underpinnings of inequity and avoid using it in a way that perpetuates the idea of race as a surrogate for biology. So before I get into my content, I want to acknowledge a couple of things. One is that talks about race and related issues make a lot of people feel a little bit uncomfortable. And some of that comes from a fear that if we're talking about race, we run the risk of putting our biases, unconscious as they may be, on display for other people. And we may even run the risk of engaging in unintentionally discriminatory behaviors despite our very best intentions. But if we don't talk about these issues, we're never going to make progress, right? So it's imperative that we do so and that we give each other the space to ask questions and discuss these issues. The other thing I want to point out is that, like any community, the medical community has a history and a culture that heavily influences the way that we think about many things, including race. And a lot of those beliefs and thoughts are unconscious. So I'm going to be talking today about a lot of things that can and should be changed. And I want everyone to recognize that I'm not talking about a deficiency in any one of you as an individual. These are thoughts and kind of ways of viewing things that are ingrained in me too. These are beliefs that are held by all of us and that we're all going to need to sort of shed light on and work together to change. So with that, let's jump in. First of all, let's start with a simple definition. What is race? This is from a recent article in JAMA. Race captures a lifelong social experience. So simple as this phrase may be, to really understand what it means, we also need to understand what race is not. So let's start with genetics. Race is neither equivalent to nor a good proxy for genetics. So to understand this, let's all put on our anthropologist caps and think back to the early days of human migration. So to understand an animation that I'm about to show you, you all need to know two things. One is, when you see a star up on the board, that denotes a specific community of humans living together. When you see a star change color, that denotes a process of evolution and genetic change. So, as we all know, humans originated in the Rift Valley a very long time ago. And before leaving the Rift Valley and populating the rest of the world, humans initially migrated across much of the continent of Africa. So let's think about a specific group that broke off from the first group of humans and migrated across the African continent to a part of West Africa. So we now have two communities of humans that are initially genetically indistinct from one another, but that are now living in geographic isolation. So over time, these two communities evolved separate from one another. Eventually, humans did start to leave the area of the Rift Valley to populate the rest of the world. So let's think about another group that breaks off from the Blue Star community and migrates across the Middle East into some part of Asia. So we now have two Blue Star groups that initially are genetically indistinct from one another, but that are now living in geographic isolation. So these three communities over time continue to evolve. So these two groups, the green group and the blue group, may live on different continents, yet they share a more recent common ancestor than the blue group and the orange group, even though those two groups are on the same continent. So we used to think about genetics and race like this. We used to think that racial groups were genetically distinct from one another with a little bit of overlap due to interbreeding. But we now understand that essentially, genetically speaking, all non-Africans are really a subset of Africans because humans have been evolving on the African continent for longer than anywhere else on the planet. So you may be a person living in, let's say, modern-day Kenya, and you may be more closely genetically related to a person living in, let's say, Thailand, than to another specific African person, say, living in Namibia. So even though you belong to the same racial group, our Kenyan person and our Thai person may share a more recent common ancestor. So how do we think about this in terms of genetic diseases? Let's think about this with the examples of Tay-Sachs disease and sickle cell disease. So let's go across the country to New York City and to the borough of Brooklyn. They were studying Tay-Sachs disease specifically in the Crown Heights neighborhood of Brooklyn. In a recent census, the racial breakdown in Crown Heights was something like this. So among the 18% white population, 80% of that group was Ashkenazi Jewish. So this is a very specific ethnic group. So if you were studying Tay-Sachs disease just from the standpoint of Crown Heights, Brooklyn, you would see that Tay-Sachs disease, which is relatively common among Ashkenazi Jews and relatively uncommon among other ethnic groups, you would see that this disease is relatively common among your white population and either absent or close to it among the rest of your population. And this might lead you to draw the conclusion that Tay-Sachs disease is a white disease. But that doesn't sound quite right to us, right? We know that Ashkenazi Jews are a small subset of all white people globally, and that it's really a misnomer to call it a white disease just because in one specific geographical area, our Ashkenazi Jews make up such a large proportion of the population. So how do we think, in contrast, about sickle cell disease? So sickle cell disease is a genetic disease that occurs when someone inherits two copies of the sickle cell trait. Having heterozygosity for the sickle cell trait confers some immunity to malaria, and therefore children in malaria endemic regions have been more likely to survive if they possess one copy of the sickle cell gene. So here we have a map of parts of Africa, the Middle East, and South Asia where sickle cell disease occurs. And here we have a map of malaria endemicity. So this is a map showing average skin tone in this part of the world. So we see that sickle cell disease tracks much more closely with malaria endemicity than it does with skin tone. So how do we think about sickle cell disease in the United States? Well, it is very true that in the United States, sickle cell disease is overwhelmingly more common in our Black population. It is also true that a relatively large proportion of our Black population comes from parts of West and Central Africa in which malaria is endemic. It is also true that in terms of relative numbers, we have a relatively small population of people from other malaria endemic regions where sickle cell disease is common. So the fact that sickle cell disease is so much more common among Black people in the United States than non-Black people is really a coincidence of geography and migration. Race does not explain the disease, even if, in this case, race does track in the United States with disease. So the way we should think about this is we should be thinking of sickle cell disease as a malaria belt disease rather than as a Black disease. So some of you may be thinking, well, you know what, I practice in the United States only, so why is this distinction really important? It sounds like sort of semantics. Why does it matter? And it matters for a couple of reasons. One is that, sure, we do run the risk of missing the diagnosis in non-Black people. That's not a huge issue in the US because we test all babies born in the US for sickle cell disease. But something that's really important is that talking about a genetic disease as a race-based disease reinforces the false idea that race is equivalent to or explains genetics. So we're reinforcing a myth here by the way that we talk about sickle cell disease. And just like we wouldn't ever talk about Tay-Sachs disease as a white disease, we really shouldn't talk about sickle cell disease as a Black disease. So similar to genetics, race is neither equivalent to or a good proxy for ancestry. So to understand this, let's think about a few specific individuals, starting with Barack Obama. So Barack Obama's mother was a white woman of mixed European ancestry, and his father was a Black man who was African and specifically was from the Luo tribe, which exists in Kenya. This is actress and comedian Tracee Ellis Ross. Tracee Ellis Ross's father is Ashkenazi Jewish, and her mother, Diana Ross, believes that her family is descended from people who were forcibly brought to the US from West and Central Africa as slaves. So both of these individuals identify as Black. And though they share their racial category, they shared none of their ancestry. Even thinking about their African ancestry, we have one person who is from the Luo Kenyan tribe in East Africa, and another person whose ancestors trace to a totally different part of that continent. This is Supreme Court Justice Sonia Sotomayor. She is Puerto Rican. Puerto Ricans are of largely Spanish descent with a small component of African and indigenous descent. She identifies as Latina. This is actress Alexis Bledel. Her father is Argentine of distant German and Dutch descent, and her mother is a white American woman whose family moved to Mexico when she was a baby, grew up in Mexico, and subsequently Alexis Bledel spoke only Spanish in the home until she went to school, and she identifies as Latina. That is the category that most closely reflects her social experience. So again, we have two people who share their racial category but do not share ancestry. This is singer Ofra Haza. She is a Jew from Yemen. So Yemeni Jews are a specific ethnic population. So she is no longer alive, and I haven't heard her say this specifically, but we can make an educated guess that Ofra Haza would experience life in the United States as a white person. She is also referred to as the Madonna of the Middle East, and this is the other Madonna, who is who's of mixed Italian and French-Canadian descent. So again, we have two people who are white, one who is a Yemeni Jew, the other who is Italian and French Canadian, so we have a common racial category with different ancestry. Just to sort of hammer in this point, these two girls are fraternal twins. So though they share very literally their entire ancestry, we can make an educated guess that one of them will experience life as a white person and one as a black person. So I've heard from a lot of people, well, Naomi, I hear what you're saying, and I understand this concept that race is a social experience, but what about what I see? What do I do with the fact that I can look at two people, they look alike to me, I can guess their racial category, and they don't look like me? How do I reconcile that with race not being representative of common genes or ancestry? So this is actually a phenomenon that's been studied for a very long time in the social sciences called the cross-race effect. Here's the definition. So in other words, we see a much finer grain of difference when we look at two people who belong to our own racial or ethnic group than when we look at two people who belong to another group. This has been studied for really over 50 years in the social sciences and has made it into many different fields of academic study, but really not into medicine, so I imagine many of you have never heard of it before. It's become paramount to the field of criminology, as it's become widely known that eyewitnesses frequently misidentify suspects when the suspects are of a different race than the eyewitness. So here's an example. These two women, Lucy Liu on the left and Lisa Ling on the right, when we look at them side by side, they really don't look that much alike. We can easily distinguish them. Yet when these two women are not in the same room, they are mistaken for each other all the time. And they find this very perplexing and very frustrating. In fact, Lucy Liu said, it's like saying Hillary Clinton looks like Janet Reno. So how do we do this? Well, there are two mechanisms by which we do this. First of all, the specific facial features that any one of us hones in on when we confront a face are those features that help us differentiate two people of our own group. So those features are different whether you're Asian, Black, white, Latino, or part of a small ethnic group. The other way is that when we're looking at someone who we instinctively recognize as being part of our group, we actually hone in on the relationships between the facial features, not just the features themselves. And when we're looking at someone of a different group, we sort of identify just individual features. So when we look at someone of our own group, that tendency allows us to individuate that person, whereas looking at someone of a different group, we categorize. And in fact, we actually use different neural pathways that have been studied through EEG and functional MRI to do these two things. So it's important to note that it is far from ideal that we do this, but all humans do it. All racial groups studied in the United States as well as outside of the US do this. What's really important is for us to, now that we know about this effect, for us to not allow our idea or our notion that two people of a different group look alike allow us to make assumptions about them being any more biologically closely linked than two people of our own group. So this is a collage from a recent National Geographic showing people from across the African continent. And what we see is there really is no one distinctly African phenotype. Sure, we don't see anyone with as light skin as some of the lightest people on the planet, but we see a range of skin tones, hair tones and textures, and facial features. There's no one African phenotype. Yet when we identify two people as either African or Black, we make a lot of assumptions about them being closely biologically related. For example, we may see someone like author Chimamanda Ngozi Adichie, and many of us would look at her particular cluster of facial features. We may not recognize them as typical of Igbo Nigerian people, but many of us would sort of be able to place this cluster of features as belonging to some African group. Likewise, this is Ethiopian President Sahle-Work Zewde, And many of us would look at her cluster of features, and that we may not recognize them as being typical of Abyssinian Ethiopians. We would recognize them as part of an African group. So even though these two women phenotypically really don't look alike, we would still make a lot of subconscious assumptions about them being biologically linked. And again, this isn't because any of us are sort of bad people or we do this intentionally. This is how we've been acculturated to think, both in the United States as well as in the medical field. And race really isn't just about skin tone, is it? So this gentleman has very dark skin, yet many of us would recognize this particular cluster of features and be able to put him somewhere in South Asia. However, many of us would look at these two women and probably wouldn't recognize their cluster of features. So these women are Aboriginal Australian. So most of us not recognizing that would simply then fall back on skin tone and make assumptions about them being Black and link them biologically to the two women on the last slide. And how about these kids? So I'm going to share my experience. So I moved to the West Coast, to Seattle, about 6 years ago. Before moving to the West Coast, I had neither met nor known almost anybody from the Pacific Islands. Since moving to Seattle, I now know many people from the Pacific Islands. Before I moved to Seattle, I think I probably would have, if I encountered these kids, would have sort of unconsciously labeled them as Black. But now that I interact with and know many people from the Pacific Islands, I think I would be able to place their cluster of features as belonging to Pacific Islanders. So I ask you, which boxes in a census do you think the people on this slide and the last slide would check? And what would those boxes tell us about what they do have in common versus what they don't have in common? Social experience, biology. Okay, so I imagine many of your heads are now spinning and you're thinking, oh, so I don't understand, what is race? It's not this, it's not that, it's not this other thing. So again, race is very hard to define as anything other than a lifelong social experience. So how do we collect data about race? So we've been collecting data about race in the United States since 1790, since the first census. On the first census, these were the racial categories that were used, right? It seems like so archaic, it's almost funny. And on our most recent census, these were the categories that were used. Every 10 years, the US Census is collected, and every 10 years since 1790, the racial categories that we've used have changed to reflect the most culturally salient categories at the time. So we sort of think about race as being this concrete scientific factor, but it's not. It's this thing that constantly changes with culture, isn't it? Here's another complicating factor. So this is a study that I first saw presented by Dr. Camara Phyllis-Jones in this room a couple years ago in her fabulous talk on social determinants of health, and it totally floored me. So hopefully it will do the same for you. So Dr. Jones and her colleagues drew on data from a large national phone survey in which they asked participants, what racial group do you belong to? So that's self-identified race. And how would you classify your health? As excellent, very good, fair, or poor. So, social determinants of health 101, no one will be surprised to see that the white participants reported better health than Black, Hispanic, American Indian, and Alaska Native participants. However, the researchers then asked people, okay, what racial group do you think that other people identify you as belonging to? So that's socially defined race. So the group that said, among the group that said, I am Hispanic and others classify me as Hispanic, about 40% reported excellent or very good health. Among the group that said, I'm Hispanic, but other people identify me as white, 53.7% reported excellent or very good health. And these numbers were significantly different. Finally, among the white group, about 59% of people reported excellent or very good health. And these two groups were not significantly different. So the same pattern was found among American, Indian, and Alaska Native people. Yet this does not reflect how we collect information about race, right? It's kind of all loose self-report. We don't ask people to stratify based on how others see them versus how they see themselves. So let's put all of this that I've been talking about together in a case to highlight two things. One, some of the issues with how we collect data about race, and two, to highlight how we can start to think differently in our clinical practice about the idea of race. So, we have Mr. Smith. He's a 47-year-old generally healthy man. He comes in with, ding, 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 spoiler alert, symptoms of a deep vein thrombosis. And he has essential hypertension and chronic kidney disease. His only medication is amlodipine. He's an engineer, lives with his wife and kids. No substance use disorder. His exam is fairly unremarkable, and his labs are notable for a stable creatinine over quite a while of around 2.5. So you diagnose Mr. Smith with a blood clot and tell him he's going to need to take a blood thinner. And his one request is, hey, doctor, if possible, I'd really like to be on a once-a-day medicine. I just know that if I'm supposed to take something twice a day, I'm going to forget sometimes. So a great option for that is rivaroxaban. And like with many medications, one needs to consider a patient's kidney function due to safety reasons when administering this medicine. So generally for rivaroxaban, we don't give it to patients with an estimated GFR of less than 30. So pause for a second. There are a lot of issues with GFR and its clinical application that I'm going to massively oversimplify and that are beyond the scope of this talk, but I'm using GFR to illustrate a larger point about race. So in light of that, bear with me. So we know that his creatinine is 2.5. Does Mr. Smith's eGFR, is it at a level that's high enough that we can safely use this medication? In order to figure this out, let's go to one of our GFR estimator calculators. So here we go. So let's start with sex. He's male. Black race, I'm not so sure. Hypothetically, let's say yes, he's black. Let's fill in his age and his creatinine, and we get a GFR of 34, so that's above our cutoff. But what if we change his race to no, since we're not totally sure? Then we get down to 29, and we see that this crosses a range that is of significance in our clinical decision making. So this is how we see it reported in EPIC and ORCA. There are a couple of issues with this. One, you will all notice that we have many patients who do not fall into either one of these categories. Another issue is that as we saw in the calculator, we see black and white. Then here we have African American and European American. Yet those two things aren't exactly the same, right? African Americans are a subset of black people globally, and European Americans, likewise, doesn't really represent all white people globally, and there's a lot of crossover. So that's one issue. All right. So in order to figure out whether or not we use black race or white race for this patient, we're going to look at a study that highlights where it came from. And in order to understand the study, you're all going to need to know a couple of basics that many of you already know, but just to get us on the same page. One is the difference between measured GFR and estimated GFR. So we can actually measure a patient's GFR by administering an exogenous substance that is only cleared by the kidneys and looking at the rate of clearance through the urine. So doing this is cumbersome, expensive, time-consuming, and totally impractical on a day-to-day clinical basis. So several equations have been developed using readily available variables to try to estimate patients' GFR. So these are the three most common ones. I'm going to be talking about the third one, CKD-EPI, and I've selected that because, first of all, it's widely used in a lot of centers in the US, and second of all, it's the most recently developed equation and therefore should reflect our most up-to-date thinking about race. So to find out if we use this, which category we use for our patient, we need to ask who was studied in the CKD-EPI equation study, why do we use a race correction in the first place, And does the race correction apply for my patient? Does he fit one or the other study population? So, as for who was studied, to derive the CKD-EPI equation, researchers drew on data from about 8,000 patients coming from 10 different studies, all done in the United States. They looked at data from another 4,000 patients to validate their equation. Nowhere in the paper is race defined or discussed, so we don't know how the race data were collected in the source papers. We can make an educated guess that likely in those source papers, the questions about race that were administered to patients looked something like this, although there may have been some differences in how those data were collected in the source studies. So let's hone in on this. Remember, the study was done specifically in the United States. So we're talking about people who are Black in the United States, which doesn't represent Black people globally, right? There are aspects of experience of being a Black person in the United States that are unique to that group and that don't cross over into Black people in, say, Africa or Australia. Furthermore, we also have a large proportion of our Black population in the United States who trace some of their ancestry to parts of West and Central Africa. So there may be enough of a proportion of that group that does share some of their ancestry or genetic background. So there could be biological features that are unique to the group of patients studied that are not representative of Black people globally. So we have potential confounders of social experience, and we also have potential confounders that we may have a much more narrow ethnic group than is representative of that group as a whole. So why do we use a race correction? So what the researchers who developed this equation were trying to account for was this. It has been found in the United States in many different studies that at a specific creatinine level, hypothetically say 2.5, the average person who checks the box for black will have a higher measured GFR and better kidney function than the average person who checks the box for white. So this is a real finding that's been repeated many times. So the researchers were trying to account for this. Here's what they say in their study. I'll give you a second to read it. Okay, so let's unpack this a little bit. So we see both in this study as well as in many other studies about GFR, the idea that race is a surrogate for muscle mass, which is representative of creatinine. So where does that come from? The authors reference this paper here. So if you look at this paper, it discusses in detail the relationship between several variables and creatinine, including age, sex, pregnancy status, presence of muscle wasting disorders. Nowhere in this paper is there any mention of race and its relationship with creatinine level. Furthermore, we see throughout the literature on GFR, again, this idea about race being a surrogate for muscle mass. So often, this assertion is made without any reference or with a reference that really doesn't justify it. The one paper that I was able to find that discusses it is a paper done in 1985 at a single center in which 150 Black participants and white participants were asked about their race and then had their muscle mass actually measured. And in that specific group, it was found that the Black group had a higher muscle mass than the white group. So we've been making this assertion year after year for over 30 years based on a single center study with 150 patients done in the United States, and yet we're extrapolating that to a global population represented by a racial group, which is a social experience. So, we try to be objective and precise in medicine, and I think this really doesn't fit our standards for our field, right? Yet we repeat this notion over and over, and I don't think anyone's doing it on purpose. I think this is, again, how we have been acculturated to think about race in the medical field, and we sort of forget to question these old assertions. Okay. So I want to go back to this for a second and note something that's really important. In South Africa, Congo, and several other African countries, the race correction, if you will, is not used because using the race correction does not improve estimations of GFR among the Black population in those countries. So again, we found this physiologic difference in the United States. It does not look the same in other countries if you stratify by racial group. So there's got to be something else at play that's much more specific than race. Again, it could be something having to do with environmental exposures related to social experience, and it could also be that our Black population is actually sort of skewed by a large proportion of a much more narrow ethnic population. So does the race correction apply for my patient? So what if he knows that his ancestors have been African American for several generations? So now that we've actively thought through who is included in those studies, it would be reasonable to use the so-called race correction for this patient because he probably does fit into the population that was sampled in the study. What if he's biracial? What if he's African American and Irish, Lebanese, Puerto Rican? We really don't know, do we? The questions that we ask looking through the CKD-EPI study really don't help us answer this question in this scenario. So in that case, what we can do is we can think of GFR as a range. We can think of his GFR as somewhere between 29 and 34, and we can sort of analyze the pros and cons of using rivaroxaban. What if we get it wrong? What if we get it right? Do we need to maybe make one decision and monitor him a little more closely? Should we use a different medicine? What if he's an Ethiopian immigrant? So that group really was not taken into account in our study. And so given that, along with studies showing that the race correction doesn't work in some African populations, it really wouldn't necessarily be appropriate to use that race correction, would it? And that's something that we would not know if we sort of took the race category in the paper at face value and didn't go through this process of asking more questions in light of what we all now know about the myths and fallacies associated with race. So let's not pick on the field of nephrology or the CKD-EPI researchers too much because they're really not doing anything that's all that different than what's done all the time every day in medicine. 80% of published medical research utilizes race as a variable. Not only that, but to get federal funding, it is actually often required to collect data on minority subjects for obvious reasons, but also to stratify one's data based on race, with no further directions about best practices and how to do that. This is done in every discipline in the medical field. Race is very rarely defined or discussed. And race is used as a proxy for all kinds of other things. It's really a shortcut that's used to explain some sort of biological difference, or sometimes even to explain categories that pertain to specific genetic populations or ancestral populations. And like we saw with using race as a surrogate for muscle mass, it's rarely discussed in depth why it's being used as a proxy. And there are all kinds of sort of repeated myths about race being a proxy for biological features that we sort of take at face value and repeat without really having good studies to back up our assertions. So when we find a significant difference in an outcome or disease prevalence or response to a medication in association with race, we often make assertions like this. After controlling for other variables, race was still significant, and then we move on. Making an assertion like this applies that race is an inherent biological feature of the population in a way that someone's genes would be, in a way that their age would be, in a way that their sex would be. Whereas really there are so many potential confounders in association with race that we can never truly say that we've controlled for all of them. When we find a difference in outcome in association with race, we can and should discuss what some of the factors may be that could explain that. And that can become the source for future studies that can allow us to better understand health inequity. So that's a way that we can use the concept of race in a beneficial manner rather than in a negative way that reinforces biased and archaic ideas about race being equivalent to biology. Similarly, like I mentioned earlier, there may be times in which our racial category in a particular study actually represents a much smaller community. For example, if you're doing a study at Columbia University with patients from your neighborhood community, your Latino group would be very largely people from the Dominican Republic, which may share some important aspect of common ancestry or some gene that could explain a difference, but it's not equivalent to race in that scenario. So, this is my final slide. If you remember one thing from this study, or sorry, from this talk, let it be this. Race captures a lifelong social experience, and it's really impossible to define in other terms. The categories that we use for race change constantly to reflect those categories that are most salient culturally. Racial categories were never meant to be these sort of clearly delineated scientific categories, yet we use them as if they were. And that's really not very scientific, and it's quite haphazard. So my recommendations for you all to start to change the way that you as individuals and that we as a community think about, talk about, and teach about race are as follows. First of all, avoid equating race with genetics or ancestry. So when you hear yourself talking about race or thinking about race, it's going to take a process of actively resisting the urge to do this because of how strongly we've been acculturated to think about race in these terms. If you are a researcher, be specific about who is in your study. Is your racial group truly representative of that entire racial group globally, or is it actually a narrower population that has a particular social experience that is unique? Likewise, if you are reading a clinical study and utilizing the data from it to apply it to a clinical scenario, don't take those racial categories at face value. Go back and actually think more critically and more precisely about who was included in that study and whether or not your patient truly fits that study population. Third, avoid using race as a proxy for physiology. And don't do this just because we've done it before. So if you are a researcher and you are tempted to do this, there are a few things that should be described in your paper. One is you should be explicit about why you're using race as a proxy and why there isn't a better thing that you could use instead of race. Two, we should all require it of ourselves and others that we cite references when we make assertions about race in relation to physiologic features. And three, one can and should discuss the potential limitations and confounders inherent in the use of race as a proxy for whatever it is we're using it for. So by doing these things, we can start to use the concept of race in a beneficial way. So race is important, right? Race has very important health consequences. We should use the concept of race to highlight and understand health inequity. That is a beneficial use. But we should avoid, going a little too fast, but we should avoid using it in a negative way that can reinforce false notions and myths about race being equivalent to biology. So doing all of this requires us as a community totally shifting our perspective about how we think about race to more correctly reflect what we know about race at this point from genetics and social sciences. So again, I mentioned this in the beginning. Doing this is no one person's responsibility. So many of you may have heard me sort of highlight aspects of thinking that you may have thought, oh yeah, I've been thinking that way. Ooh, that's bad. it's not your fault and it's not your individual responsibility to change this. This isn't about a personal deficiency. This is about our culture as a community, and we're all going to have to work together to make the changes that I've talked about. And that is it. And I think we've got plenty of time for questions.
There we go. Absolutely brilliant talk. What about the term ethnicity?
Yeah, so the question was, what about the term ethnicity, race versus ethnicity? So in the social science literature, there is some disagreement about how to define ethnicity in relation to race. I will say the way that I use it, and many people use it, is as this. Race denotes a large social category that has to do with how people are perceived in their culture at large, and ethnicity pertains to specific populations that share ancestry closely. For example, Ofra Haza, who I mentioned earlier, who is a Yemeni Jew, that would be considered an ethnic population. But like I said, in the social sciences, there is some debate as to how exactly to define these, and some people describe them as the same thing. So it's not totally accepted, and I think if we're using either term, we should define them a little more specifically, especially if we're using them in the context of a paper or a study.
Hi, Naomi.
Hey.
Wow, that's loud. Congratulations on a really wonderful talk. I found it very, very helpful. I'm curious to know, as we think about our education of medical students, the use of race in our medical language, especially as we introduce concepts of chief concern and identification, and how often we see race being included in non-white populations in that construct, and how that leads to fallacies in thinking, and how you think, what's your advice to us as instructors around how language, especially around race, should be used as we educate our trainees?
Yeah, so this is a tough one. This is about how to treat race when we're sort of talking about individual patients in terms of an identifier. So like I said in my talk, you know, race is important because race has real health and biological consequences as a result of inequities. And we need to understand that and address that. But we also know that we run the risk, once we identify someone as belonging to a particular racial group, of enacting all kinds of subconscious biases, even despite the best of our intentions. So what do we do with that? Here's what I would say. I no longer use it as an identifier. I don't think it's particularly helpful or meaningful in terms of biology. So what I tell students is this: if you're going to include race, I want you to be able to tell me really clearly and succinctly why you're including it and why it's of significance for this particular patient. If you find yourself only thinking about it as being significant if the person is non-white, we need to talk about that and explore it and think about what it means. So I don't think there's an exact answer that we should never use it or we should always. I definitely don't think we should always use it. I don't think I can fully say that I don't think we should ever use it, but I think we need to talk a lot about what it means and be really clear about why we're using it. And I think we should rarely use it, honestly. I think maybe sometimes where it's of use is if a person expresses to us that they've experienced discrimination. Sometimes they may not necessarily be aware of it, but if someone's had that experience, it would be helpful to me as a primary care physician to know that they've had that experience so I can sort of confront that and address it head on. Yeah.
I've actually had students say, why can't we just name it and say a person experiencing racism?
Yeah. Say that instead of their race. Yeah, that's great. I think that's a great idea. It doesn't really matter, does it? Yeah. Great idea by your students. I mean, I think, I sort of alluded to this at the beginning, but doing better in light of this is going to require all of us having a lot of conversations. And there are going to be many areas in which people have differing opinions, and that's okay. And we can and should discuss our best practices and be open to different ideas. That's kind of how I approach it.
Great talk, Naomi. It's sort of a similar but slightly different question. As the UW, I feel like, has become more progressive in changing in our medical record system how people can define their gender markers and their preferred name, do you think that we should sort of, in order to encompass social experience and the fact that people have, multi-ethnic backgrounds, et cetera, be able to be more, permissive in what's allowed in entering the medical record in that sort of demographics category, where people right now have a single race choice sort of in the 5 categories?
Yeah.
That doesn't really, as you mentioned, capture.
Absolutely. I do think we need more categories, and we need to be more open-minded about how we collect those data. Specifically, I think we need to be careful to differentiate between ancestry and race, which is a social experience. So many of our patients may not know what their ancestry is, but some do. So we should give people the opportunity to state what their ancestry is. If they don't know what it is, then we should have a way to account for that. And when we're talking about collecting data on racial experience, which is, again, important to understand health inequity, then I do think we need to have more categories and more way of explaining or of accounting for people who identify as multiracial. And furthermore, we need to understand better whether we should be using categories saying, if you had to pick one racial group, which do you identify with most closely? How do you think other people identify you? All these things may be really salient in terms of exposures, such as experience of discrimination and toxic stress. And we really don't know how all of those variables are associated with health outcomes because we just don't collect data in that way.
That was great, Naomi. When I think back to my own training 20 years ago, the point at which race was talked about the most in terms of guiding clinical decisions was the choice of class of antihypertensive agent. And, but I don't hear much about that as much lately. And I'm wondering, do you have thoughts about the evidence base for that way of thinking about choice of antihypertensive agent?
Yeah. So there are situations like for antihypertensives where data has been collected that does show a significant difference in association with race. But like I talked about with the study on CKD-EPI, when we're looking at data like that, it's already been taken, so we can't change the way those data were collected. But what we can do is change the way that we interpret them. So when looking at like the All-Hat study, what we should be doing is looking at it and thinking, who was actually in that study? And again, is that population truly representative of Black people globally? For example, we have a ton of East African patients in our patient population, especially at Harborview and at Pioneer Square where I work. And a lot of these studies were done among people who are Black in the United States, which I do not see as being related in a meaningful way to my East African patients. So I don't know if that really answers your question versus makes it even messier, but I think at least to start with the studies that we already have, that many of which are, in a lot of ways good studies, we can change the way we interpret those studies as we sort of work to shift the way that we collect data in the future. Okay, good.